In this video, we will be talking about the kidneys, a pair of retroperitoneal organs located in the paravertebral gutter of the posterior abdominal region. Why should we learn about kidneys? Is it just to pass exams? Absolutely not. A detailed understanding of the kidneys, their anatomical relations, location, surface markings, internal structure, blood supply, and innervation is essential in medical practice, especially for diagnosing renal pathologies. Let's consider a clinical scenario. A 50-year-old man presents with a gradual onset of fever and a constant dull pain in the lower back radiating to the groin. He also reports dysuria and urinary urgency. To associate these symptoms with a kidney-related issue, anatomical knowledge is key. Location and orientation. Contrary to the intuitive belief that kidneys are located in the lower abdomen or pelvis, they are actually positioned high up in the abdomen. Anteriorly, they lie in the left and right hypochondriac and lumbar regions. Posteriorly, they are related to the renal angle, located between the inferior border of the 12th rib and the lateral border of the erectospinae muscle. The kidneys extend from the T12 to L3 vertebrae, with the right kidney slightly lower due to the large right lobe of the liver. Each kidney is enveloped in a fibrous true capsule and is retroperitoneal, meaning it lies posterior to the parietal peritoneum. Importantly, the kidneys are obliquely oriented, with their anterior and posterior surfaces directed anterolaterally and posteromedially. Understanding this orientation is crucial for procedures like percutaneous nephrostomy or endourological interventions. Renal hilum and surrounding structures. On the anteromedial surface, each kidney has a vertical slit, the renal hilum, which leads into the renal sinus. The arrangement of structures in the renal hilum is, first, the renal vein anteriorly, the renal artery in the middle, and the renal pelvis posteriorly. The right renal hilum lies just below the transpyloric plane, and the left renal hilum lies just above it. Posteromedial relations. Both kidneys share similar posterior muscular and neurovascular relations. Superiorly, you have the diaphragm, and inferiorly, from medial to lateral, you have the psoas major, quadratus lumborum, and transversus abdominis muscles. Several nerves pass posterior to the kidneys. You have the subcostal nerve and vessels, the iliohypogastric nerve, and the ilioinguinal nerve. When you consider the rib relations, left kidney overlies the 11th and 12th ribs, while the right kidney overlies only the 12th rib. The renal angle, located posteriorly, is a key clinical landmark. Tenderness here may indicate renal inflammation or infection. Also note, the diaphragm separates the kidneys from the costodiaphragmatic recess of the pleura, putting the pleura at risk during posterior surgical approaches to the kidney. Anterolateral relations. When we consider the right kidney, the superior pole is related to the right suprarenal gland, and inferiorly, it's related to the liver and coils of the small intestine, separated by the peritoneum. It's also directly related to the descending duodenum and right colic or hepatic flexion. When you consider the left kidney, the superior pole is related to the left suprarenal gland, and anterosuperiorly, it is related to the stomach and spleen, both being intraperitoneal. Inferiorly, it's related to the tail of the pancreas, which is retroperitoneal, the left colic or splenic flexure, and jejunal loops, which are intraperitoneal. Fascial coverings of the kidneys. The kidneys are enclosed in several layers of connective tissue, the first being the true capsule, which is a tough fibrous layer directly adherent to the kidney surface and lining the renal sinus. The second is the renal fascia or Gerota's fascia, which is a condensation of connective tissue derived from the parietal peritoneum anteriorly and posterior abdominal wall fascia posteriorly. It encloses the kidney and perinephric fat. Superiorly, it encloses the suprarenal gland separated by a septum. Inferiorly, it continues along the ureter, and laterally, it fuses with the transversalis fascia. Medially, it merges with the adventitia of renal vessels, the perinephric space. Between the true capsule and the renal fascia lies the perinephric fat, which occupies the perinephric space. The clinical relevance of this is that infections or hemorrhage in this space can track inferiorly within the renal fascia, potentially reaching the pelvis. Internal structure of the kidney. In cross-section, we can see that the cortex, or the outer region, contains renal corpuscles, which includes glomeruli and Bowman's capsules, and convoluted tubules. The medulla, or inner region, is composed of medullary pyramids, which contain loops of Henle and collecting ducts. Pyramids apices, which are renal papillae, drain into minor calyces, and minor calyces drain into major calyces, usually being superior, middle, and inferior, which drain into the renal pelvis, which then drains into the ureter. Renal columns are cortical tissue between these pyramids. The nephron, or functional unit. Each kidney contains approximately 1 million nephrons, which are composed of a renal corpuscle and a renal tubule. A renal corpuscle is made of a glomerulus and a Bowman's capsule. The glomerulus is a capillary tuft, and the Bowman's capsule collects the filtrate. The renal tubule consists of a proximal convoluted tubule, the loop of Henle, a distal convoluted tubule, and a collecting duct. There are two types of nephrons, cortical and juxtamedullary. Renal vasculature, a journey through blood flow. This includes the renal artery from abdominal aorta, segmental arteries, interlobar arteries, arcuate arteries, interlobular arteries, afferent arterioles, glomerulus, efferent arterioles, peritubular capillaries, or vasa recta. Venous drainage reverses this pathway from interlobular veins, arcuate veins, interlobar veins, segmental veins to the renal vein, and finally the inferior vena cava. Note that renal artery and vein variations are common. Lymphatic drainage. Lymph drainage of visceral structures follow arterial supply. Abdominal viscera are supplied by pre-aortic vessels, therefore these structures are drained by pre-aortic lymph nodes. Most pelvic viscera are supplied by para-aortic vessels, therefore these structures are drained by para-aortic lymph nodes. Therefore, kidney lymph drains into para-aortic lymph nodes located near the origin of the renal arteries. A clinical insight of renal vasculature is a varicocele. The left gonadal vein drains into the left renal vein at a right angle, which can result in higher pressure and pooling, leading to varicocele, especially on the left side. Renal innervation and referred pain. The kidneys receive autonomic innervation from both sympathetic and parasympathetic systems. Sympathetic preganglionic neurons from T12 to L1 spinal cord segments. These travel via thoracic and lumbar splanchnic nerves. They synapse in the celiac and aorticorenal ganglia, and they function in vasomotor control, influencing renal blood flow and renin secretion. Sensory or afferent fibers. These carry pain signals, for example from a kidney stone. They travel alongside sympathetic fibers back to T12 to L1, explaining referred pain to the flank and lower back, and also to the groin and genital region following dermatomes. But there's a curious twist. Some afferents might run alongside the vagal fibers, possibly explaining the nausea and vomiting that can accompany renal pain. Imagine you have a kidney stone causing havoc in the calyces or renal pelvis. The pain from renal colic takes a scenic route, passing through the celiac plexus, traveling via the splanchnic nerves to the sympathetic trunk, and finally reaching the T12 to L1 spinal nerves. And there you have it, a sneak peek into the fascinating world of renal nerves, and their role in the symphony of kidney function and pain perception. In conclusion, understanding the detailed anatomy of the kidneys, from their location, relations, internal structure, vascular supply and innervation, is vital not only for exams but also for diagnosing and managing renal and urological conditions in real-world clinical practice.